You know, when someone says they have vertigo, most of us just think of simple dizziness. But to a doctor, well, that's the opening scene of a high-stakes medical mystery. It's this one powerful clue that kicks off a race against time to figure out what the body's trying to say. Is it just a simple glitch, or is it a warning sign of something way more serious? Let's follow the clues together. So, here's our game plan. We're gonna walk through the exact same steps a doctor takes to crack the case of vertigo. We'll start by defining the scene, then check for immediate dangers, follow the evidence to the source, and finally, look at the usual suspects before we close the case with the right treatment. Okay, so every investigation has to start at the crime scene, right? And for us, that's the symptom itself. Before we can even think about solving the mystery, we have to know exactly what we're looking at. Now, this is so important. Vertigo isn't just feeling lightheaded or a little off balance. No, it's the very specific, very false sensation that you or the entire room around you are spinning. And remember, this is a huge clue, but it's not the diagnosis. It's just the first piece of the puzzle. Before any detective starts bagging up evidence, what do? They secure the area. They make sure there are no immediate threats. And in medicine, it is exactly the same. The very first step is to screen for any life-threatening emergencies. Doctors have a really quick checklist for this, and a great way to remember it is the acronym STOMP. Each of these letters stands for a major red flag. We're talking slurred speech, not being able to sit up straight, that points away from a simple ear issue and directly towards a brain emergency, like a stroke. If any of these are happening, the whole investigation changes in a heartbeat. Okay, so once we know the patient is stable, the entire investigation really pivots on one central question. Is this problem coming from the inner ear's balance system, what we call peripheral, or is it coming from the brain itself, which we call central? This is our first big lead, and it determines everything that comes next. And you know, the first clues come from the patient's story. It's all in the details. As you can see here, peripheral vertigo, the ear stuff, it tends to be really sudden, super intense, and often set off by just moving your head. But central, or brain-related vertigo, that can be more constant, kind of sneaky, and it often brings along other neurological symptoms like double vision or a really bad headache. The details here start to build our case. All right, so with a working theory based on the story, it's time to bring out the specialized toolkit. A good doctor doesn't just listen. They performed these very specific physical tests to examine the evidence with their own hands and confirm what they're suspecting. And this brings us to a really fascinating question. You'd think we'd need a big, fancy, multi-million-dollar scanner right away, wouldn't you? But how can a doctor get a surprisingly accurate answer right there at the bedside? Well, the answer is one of the most elegant exams in all of medicine. It's called the HINTS exam. The first part is the head impulse test. The doctor asks the patient to just stare at their nose, then gives their head a quick, small turn. Now, if the eyes have to jump back to the target to refocus, that's called a corrective saccade. And here's the wild part. This abnormal result is actually good news. It points to an inner ear problem. It's a normal result where the eyes stay perfectly locked on target. That is a huge red flag for a stroke. Next, the doctor looks closely at something called nystagmus. That's just an involuntary jerking of the eyes. The pattern of these movements works just like a fingerprint. If the eyes are beating only in one direction, side to side, and it gets a little better when the patient focuses on something, that points to the ear. But if the beating is straight up and down, or if it changes direction when they look left versus right, that is a classic clue for a problem in the brain. And the last piece of this exam is the test of skew. By covering one eye and then the other, the doctor is looking for any tiny vertical shift as the uncovered eye locks back on target. If the eyes are perfectly aligned, that's great news. But if one eye has to move up or down to get back in line, that's called a skew deviation, and it is a highly specific sign of a problem deep in the brainstem. So this all leads to a foundational rule in emergency medicine. If a patient comes in with nonstop vertigo, but their head impulse test is normal, you have to assume it's a stroke. And get this, in the first day or two, this simple bedside HINTS exam can actually be more sensitive than an early MRI for finding a stroke in the back part of the brain. That's just an incredible piece of medical detective work. Okay, so we've gathered our evidence from the patient's story and the physical exam. Now it's time to look at our lineup of the most common culprits, the usual suspects that cause vertigo. Suspect number one, and by far the most common offender, is BPPV. This is caused by these tiny little calcium crystals, you can think of them as ear rocks, that break loose and float into the wrong part of the inner ear. The classic story is really brief, intense spinning. We're talking less than a minute, triggered by simple things like rolling over in bed or looking up at a high shelf. Next in the lineup, we've got vestibular neuritis and labyrinthitis. These two are related, and they often show up after you've had a virus. Both of them cause this sudden, severe, non-stop vertigo that can last for days. The key clue to tell them apart is your hearing. Labyrinthitis comes with hearing loss or ringing in the ears, while vestibular neuritis doesn't. And then you have Meniere's disease. This one has a very unique signature, a classic triad of symptoms that come in attacks. You get vertigo that lasts for hours, hearing loss that comes and goes, and this distinct feeling of fullness or ringing in just one ear. When those three things show up together, Meniere's becomes a prime suspect. So once our detective has identified the right culprit, it's finally time to close the case. And the treatment for vertigo is absolutely not one size fits all. It has to be tailored precisely to whatever the underlying cause is. And this is where that correct diagnosis means everything. For BPPV, the fix can be a simple set of head movements called the Epley maneuver that just uses gravity to put those loose crystals back where they belong. It's amazing. But for a central cause, like a stroke, that is an all-out emergency with protocols and medications to prevent more brain damage. The diagnosis dictates the entire plan. So in the end, vertigo isn't just a spinning room. It's a message. It's a signal from this incredibly complex wiring that connects your ears, your eyes, and your brain to tell you where you are in space. And the real question, the one that every good medical detective has to ask, is what exactly is that signal trying to tell you?